I don't know how things work in Hamilton, Laiya, but there's no planet where you can get an MRI in the Emerge in Toronto or the Sioux.
Yeah, that's, I want to know how they made that happen.
This is The Rounds Table. All right, welcome back, Rounds Table, Intern at Work, and MedPods listeners. We have two articles, both rapid fire, both I think of interest, and I'm joined again by Dr. Laiya Carayannopoulos. Laiya, do you want to start with your article first?
So this is a phase 3 trial of the DPP-1 inhibitor Brensocatib. They're always such good names. In bronchiectasis, published in NEJM in April of 2025.
Yeah, I'm very familiar with the DPP-4 inhibitors, but a DPP-1 inhibitor for bronchiectasis, I'm clearly going to learn something new. What was a research question for this study?
Yeah, so the question was, is Brensocatib, this DPP-1 inhibitor, as we said, effective at decreasing the rate of exacerbations of bronchiectasis in patients with non-cystic fibrosis bronchiectasis?
Yeah, I love it. I mean, I see patients with bronchiectasis. In my mind as a general internist, I really think I don't know what the treatments are. So it's super exciting to see an RCT on a treatment for bronchiectasis. But why did this catch your eye?
I mean, for the reasons you just said, really, you see it as a condition, you just kind of go, well, damn, what are we going to do about this? Up until now, there's been nothing dedicated to bronchiectasis specifically as like a directed treatment. And so just, for some context, bronchiectasis is this inflammatory lung condition that results in a huge burden of symptoms and has a big impact on lung function, quality of life, mortality. There's a lot of underlying causes, like there's different pathways to get there, but a central pathology here is this neutrophil-mediated inflammation that triggers this cascade of downstream damage and progression of lung disease. And so I learned something too here, that there's something called these neutrophil serine proteases that contribute to this spiral. And in patients who have bronchiectasis, when they test, those that have higher concentrations of these have been found to have more severe disease and dysfunction. And so what this drug does is it inhibits DPP-1. So it effectively blocks the conversion of these serine protease precursors to the functional enzymes. And in a phase 2 trial, it seemed to prolong the time to first exacerbation and led to a lower rate of exacerbation compared to placebo.
Neat. And I was chatting with a medical student. She wants to become an ICU doctor. And I was saying, very often there's overlap between like resp and ICU. And in some countries you do respirology. But with your training as an intensivist, like how many blocks of respirology do ICU fellows do these days? And do you get a ton of exposure to these more niche resp conditions during that training? I was wondering about that.
Yeah, in Canada, at least, unless it varies by program, there's no requirement to do a respirology block. So people end up doing it because you recognize that, it's important. Although I'll be honest with you, I think a lot of people look at it as an opportunity to do bronchoscopy and don't realize the relevance of the other things you can get exposed to. And certainly we see these things come up, right? Like bronchiectasis is very much familiar to us in ICU. We see the complications of it. But I would say that by and large, we get pretty shortchanged on niche training here.
Okay. So then it's sort of similar then to back in, for GIM, I think I did like one block of resp. And I'm already on a tangent. I'm going to keep going on this tangent. I was just checking with ChatGPT. I was like, what are like the causes of bronchiectasis? And this is like a swing and a miss for ChatGPT. It's so vague. It's like, it's related to infection, immunity, inheritance, inhalation, inflammation, infiltration. So I'm like, oh man, we're in a brief window of time before any AI is so much smarter than any human, but that window hasn't closed. Anyway, back to the study. What was the actual design here?
Yeah, so this is a double-blind RCT. It was massive, 390 sites across 35 countries.
Wow.
Yeah, pretty impressive. Patients were included if they had a clinical history consistent with bronchiectasis and confirmatory imaging within a recent time frame, and then a set number of exacerbations requiring antibiotics. So the main population was adults and adolescents. I'll come back to that in a moment, with non-CF bronchiectasis, who, as we said, have a history of exacerbations. So adults had to have had at least 2 requiring antibiotic treatment in the last 12 months, where adolescents had at least 1. The goal was only to include about 40 adolescents in the study just to look for initial safety data. It was really meant to be an adult trial. So I say adults and adolescents because technically they were included, but really the bulk of this study is 18 and up. Our intervention, so this actually had 2 intervention arms. Both were the Brensocatib drug taken orally, but it was 10 milligrams or 25 milligrams compared to placebo. The primary outcome was a lower annualized rate of pulmonary exacerbations, meaning that you calculate an annualized rate by going, okay, if the study lasts 1 year and I follow up for 1 year, well, my annualized rate is just how many exacerbations I saw by patient. If you had done it for 6 months, then you would multiply it by 2, which drives me a little bit crazy, but I won't take us off on that tangent for the time being. Other outcomes were, time to first exacerbation, how the proportion of exacerbation-free patients, and the rate of decline in lung function. Important exclusions: patients were allowed to be enrolled if they had a history of COPD or asthma, but not if they were felt to be the primary drivers of their respiratory symptoms. And then obviously having cystic fibrosis and then known or suspected immunodeficiency disorder were also exclusions.
Okay, yeah, makes sense. I mean, that is massive. 390 sites across 35 countries. It probably speaks to how common or rare bronchiectasis is and how hard it is to find patients. I know we'll editorialize eventually, but it was nice. At least they had like a kind of clinical outcome. Many of these trials are like, how much does it change their eosinophil count? And you're kind of like, what? So they already get a gold star from me for at least a somewhat clinical outcome. But yeah, what did the included patients look like?
Yeah. So they screened just shy of 2,300 patients. They randomized 1,767. And then due to circumstances like the war in Ukraine and a couple issues with compliance with good practice in the States, they ended up analyzing, oh my goodness, 1,721 in the intention to treat population. For context, they needed 1,620 adults for 90% power to detect a 30% reduction in the rate ratio for exacerbation. So they got that even when you exclude the 40 adolescents that count in that 1,700 total. The mean age was about 60. The majority actually were female, which is a rarity in so many of our trials, 64% female. The majority were white, so about 74%, 11% Asian. The majority had idiopathic bronchiectasis, about 60%. 70% of the patients had had 2 exacerbations in the past year, and then the remaining 30% had had 3 or more. So pretty moderate disease, pretty reflective of the population that we see.
Yeah, makes sense. And yeah, what did they find? Did this drug work?
The short answer is yes, it did. So the annualized rate of pulmonary exacerbations, and I'll add, it was a 1-year follow-up. So to say it's an annualized rate, it just is the rate of what happened in the study. With the 10 milligram dose, there were 1.02 events per year. With the 25, it was 1.04, and placebo had 1.29. So if we look at the rate ratio versus placebo for the 10 milligram dose, it seemed the most effective. You get 0.79, so a 21% reduction, which is pretty significant. In terms of key secondary outcomes, you again had a slower time to first exacerbation compared to placebo. So 10 milligrams had a hazard ratio of 0.81, 25 had a hazard ratio of 0.83. And in terms of the percentage of patients who remained exacerbation free at 52 weeks, which is probably the easiest way of conceptualizing it if you don't enjoy reading into what a hazard ratio means, the 10 milligram dose was 48.5. 25 milligrams was 48.5 and placebo was 40.3. So right there, you can see that more patients stayed exacerbation free with the drug compared to placebo. The other things they looked at were lung function, so change in post-bronchodilator FEV1 at 52 weeks. And interestingly, here you see this kind of U shape where you've got the 10 milligram had a decline of 50 mils, 25 milligram had a decline of 24 mils. And again, you want less of a decline, so smaller is better. And placebo had a decline of 62. So your 10 milligram dose didn't seem to have a statistically significant change or benefit in this regard, whereas the higher dose did, despite not showing quite as beneficial a difference in the rate of exacerbation. Interestingly, from a safety point of view, the overall adverse events were similar across all groups. The only one they saw that seemed to be more frequent with the drug was hyperkeratosis, and they were generally mild and resolved, but serious adverse events were similar. Death rate was low and similar between groups. If anything, the placebo group had slightly more deaths in the study.
Interesting. Yeah, and it's, that's the other primary outcome. Like when a primary outcome was like change in FEV1, it's like, how many patients come to you being like, will this drug reduce the
Change my
slope in
FEV1.
my
Yeah.
yeah.
Totally. Well, and you're like, is 24 mils really going to be? I haven't looked up the like MCID of it, but I doubt that is an an appreciable difference.
Yeah, I totally agree. It's interesting seeing, the adverse events that they did observe, like nasopharyngitis, cough, and headache. Those are the same ones that you see with DPP-4 inhibitors. The hyperkeratosis, thickened skin, that's interesting, and I wonder what that's related to. But neat. I mean, this feels very promising, feels pretty impressive, but limitations that you thought of here?
I love to dig and critique and judge, and I don't have a ton of complaints here. I would say maybe the biggest ones are the some degree of subjectivity in the exacerbation definition, because it is patient reported outcomes. But I mean, from a clinical point of view, if that's what we use, then I think reasonable to use something that's grounded in how we practice day to day. And it was adjudicated by a separate committee. So putting that aside, probably the relatively short follow-up time. I mean, a year isn't bad, but for a disease that has such a lengthy impact, it probably isn't quite enough to know how this carries forward. So that would probably be my biggest concern. But again, this was phase 3. That's not what it's meant to look at. And then once you get post-market surveillance, you hopefully start to see, these other things that come out.
Yeah, completely. And sometimes when I look at an outcome and think, geez, why did they do that? Why that duration? Or like with drugs for NASH or MASH, the primary outcome is always liver biopsy. And I'm like, that is just absurd. But then you realize sometimes it's from the regulator. Like sometimes the regulators say, no, we want this to be the primary outcome. So I'll do a deep dive some other time. But I wonder if the FDA or, EMA said, listen, 12 months is what you got to do.
Yeah. And I mean, to your point, I really appreciate that it is, I think, a patient important, relevant outcome. Like, I care if I need to get put on antibiotics more often.
For sure.
Or if I get hospital, an exacerbation matters, I think. So
yeah, totally. Agreed. Okay. And take home point?
So I think the takeaway here is that in patients with non-CF bronchiectasis, Brensocatib lowers the annualized rate of pulmonary exacerbations compared to placebo. Maybe has some other benefits in terms of lung function, and we've already editorialized that. And both doses, I guess I should say the 10 and 25 milligram doses, and it kind of remains to be seen between the two, which is better.
Yeah, and I guess too soon to say if it's practice changing, but it'll be interesting to see if this gets, market approval and could be a treatment option for this patient population.
Totally. Yeah. I mean, pending FDA approval, this would be the first dedicated therapy. And so it probably would be huge. So super interesting.
Yeah, totally. Wicked. Okay, well, we will change gears. And I can't think of a good segue because these two trials are totally unrelated.
I was gonna say there is no link here.
Yeah. There's no connection. The connection is they were published in the New England Journal of Medicine.
There we go.
In 2025. So this trial is entitled Alteplase for Posterior Circulation Ischemic Stroke at 4.5 to 24 hours.
All right. Why don't you tell us what the question was for this study?
Is IV TPA effective for patients who are presenting with a posterior circulation stroke between the hours of 4.5 and 24 hours who did not receive EVT?
Got it. And why does this matter?
Yeah, good question. So, I will zoom out, I guess, and remind the listeners when a patient presents with posterior circulation stroke, what are the types of symptoms? So Ophir Murad taught me the Ds, and that includes diplopia, dysarthria, dysphagia, dizziness. These symptoms are pretty nonspecific, and it's easy for these posterior circulation strokes to be missed as a result. The major divide, I'm not going to go into anatomy beyond just saying the main vessels we think about are posterior cerebral artery. That classically can present with a homonymous hemianopsia. It can also include a thalamic infarct, which can present however it wants. And then the other branch is vertebrobasilar, which can present with the vertigo, the dysarthria, contralateral hemiparesis, etc. So that's a little bit of a refresher on posterior circulation stroke. And another refresher is that EVT is incredibly effective when patients have a basilar thrombus, and that's new based on multiple randomized trials published in the last 12 months or so. So for patients who are presenting within 24 hours and have a basilar thrombus, EVT is the right answer. However, there are many hospitals where EVT is not possible, like the Sioux Area Hospital where I continue to work. So that's a bit of the background. A bit more background is we kind of know that for patients who present with a stroke within 4.5 hours, TPA is likely to be effective. This idea of 4.5 to 24 hours, regardless of the type of stroke, there have been some small studies and no clear benefit. When I was a med student, I was actually taught that like posterior circulation strokes, if they bleed, it's a terrible outcome, and TPA for posterior circulation stroke, you worry about bleeding. The authors didn't really note that in their intro, and they actually said the data suggests the opposite, which surprised me.
Interesting. Yeah, I wouldn't have expected that.
Yeah, me neither. But anyway, so that's the sort of groundswell, I guess, behind this trial. And the authors acknowledge the fact that, yeah, we get it. Thrombectomy is highly effective if you have a basilar artery occlusion. But again, it's not always available. And in that patient population, if they come 4.5 to 24 hours, could TPA be effective?
Got it. So what was the design here?
So open label randomized trial at 30 sites in China for patients who presented with acute posterior circulation stroke without extensive early hypodensity on CT, which is really just code for there wasn't obvious evidence of a truly infarcted tissue. As I've said, the patients presented within 4.5 to 24 hours. So some key inclusion, age 18 and up, NIH stroke scale of 1 or more. 1 is very, very minor. I'll mention that up front. They had to have an aspect score greater than 7. What the heck is an aspect score? Well, it ranges from 0 to 10. And you can have a posterior circulation aspect score with lower scores indicating more extensive infarction in the posterior circulation. So 7 or higher being, less infarction, which is, we want that sweet spot. We don't want to be giving TPA if the tissue is completely infarcted. So really important exclusion criteria: patients who showed rapid improvement of their symptoms on presentation, patients with status epilepticus, patients at high risk of bleeding, platelets less than 100, a non-adherent type of patient, and this is, their words, a life expectancy of less than 3 months, and a couple of others which we'll probably bring to life later, mainly that they had to have a really good functional status before the stroke had occurred. The intervention here was Alteplase, so 0.9 mg per kg, maximum dose of 90. The comparator was just standard of care, no placebo, just you're not going to get TPA. And the primary outcome was functional independence, defined as a Rankin score of 0 to 2. The Rankin scale is something that's used very commonly for these stroke trials. A reminder, the range goes from 0, which is like no disability, higher scores or higher disability, and 6 is death, evaluated at 90 days.
The Rankin score is this really clever composite outcome, masked as a non-composite outcome when you consider that it includes death and everything. But
yeah, exactly. And it's actually it's really interesting, it's this scale which includes all these different statuses, and in some of the TPA trials, the actual Rankin scale, when they evaluate it as an ordinal scale, sometimes the overall number doesn't vary and is the exact same between the two groups, but those with a really good functional outcome is different. So I think that has informed why more and more trials aren't actually comparing the number in the two groups and instead is focusing on this good outcomes group.
Fair. So what did the patients end up looking like?
So there was 234 patients randomized, and they didn't report the number of patients approached, which is unfortunate because I feel like that is really useful information. But I can also appreciate that with these really pragmatic trials, sometimes you aren't collecting these data, and not necessarily for bad reasons, but it's part of how pragmatic the trial is. Average age was 64, inversion of the sex distribution. So compared to your study, so 65% were men, which is what we tend to see in cardiovascular trials. 65% had hypertension at baseline. almost 100% had a Rankin score of 0 at baseline, which means really good functional status. Like you and I have a Rankin of 0.
Yeah, I'm impressed by that. That's
I know. And I can't say, like, most of the patients I'm caring for on GIM, they are not coming in with a Rankin of 0. So this will affect how we think about applying these results. Median NIH stroke scale was 3. That's a minor stroke. 35% presented between 9 to 24 hours. 40% of patients, the time was unknown. So for those individuals actually woke up with the stroke. And I'll note that rescue thrombectomy was performed in 4 patients in the TPA group and 7 patients in the standard treatment group. And actually the final point is that 62% of these patients, they had an MRI in the emergency department confirming it was a posterior circulation stroke. I don't know how things work in Hamilton, Laiya, but there's no planet where you can get an MRI in the Emerge in Toronto or the Sioux.
yeah, that's I want to know how they made that happen, because it's not a small percentage. It's very impressive. Wow. Yeah. All right. What did they find?
So the primary outcome, this really good Rankin score, very minimal disability, was observed in 90% of those who got Alteplase and 72% in the standard treatment group. That corresponded to unadjusted risk ratio of 1.23, so favoring Alteplase. But this was a small trial and there were some imbalanced characteristics. The adjusted risk ratio was not as good, but still quote unquote positive. Adjusted risk ratio of 1.16, again, suggesting better functional outcomes with Alteplase. Symptomatic intracranial hemorrhage, which I think is something that I always fear when I'm giving TPA, occurred in 1.7% in the Alteplase group and 1% in the standard of care group. And then parenchymal hematomas occurred in 3% in the Alteplase group compared to 1% in the standard treatment group. And then finally, mortality. So by day 90, it occurred in 5% in the Alteplase group and 8% in the standard treatment group.
I'm impressed by how low that hemorrhage number is. I would have expected that waiting longer from symptom onset and giving Alteplase would, but I guess, you kind of alluded to it, right? With how low the burden was of disease too and whatnot might mitigate some of that. But
yeah, I think that's a piece of it. And I also think if you give TPA to somebody who is really low risk of a bleed, and I think this trial predominantly included quote unquote like the healthiest of the healthy people presenting with a posterior circulation stroke, that's got a way into it as well, I think.
Fair. Yeah, makes sense. So looking at all this, we've alluded to a few, but what were the main limitations in your eyes?
Yeah, I think, if you just look at the abstract, you see New England and you see positive primary outcome and you think, oh man, this is a game changer. No, I don't think this is a game changer. I think the fact that it was unblinded is a really critical flaw of this study. Kudos to the authors for pulling this off, but in an unblinded study and your primary outcome is related to disability and functional status, the patients might feel like their functional status is better because they know they got the quote unquote good stuff. And the person adjudicating the outcome, even if it's blinded, can still affect that. So I think that's a major limitation. It's a small study. I think it's highly, highly selected patients. And I think the fact that so many patients had an MRI within minutes of coming to the Emerge, I can't reproduce that in any hospital I work at. And sure, if I have total diagnostic certainty with the MRI posterior circulation stroke, no signs of bleeding, no other high-risk features, those are important limitations of this study for sure.
Yeah, fair. Like the external validity, so to speak, is just so hard to apply, right? Like it's so narrow here. So what's your take-home point in that context?
Yeah, I think it's really just that TPA might be effective for mild posterior circulation stroke in a highly selected patient who gets an MRI within minutes of coming to the emergency department and presented within 4.5 to 24 hours.
Awesome. And you've already answered this one, but is it practice changing for you?
No, I definitely do not think so. It will be good to hear from card-carrying stroke neurologists. If you disagree, please let me know. Let me learn something new. But this doesn't feel like okay, we got one trial. Let's change practice. I think this has got to be reproduced a couple of times before it changes how patients are cared for.
Yeah, I agree. And I'm so curious about, to your point, the number that were screened. Like, I wonder how many got excluded just on the basis of comorbidity, like pre-existing functional status and whatnot. So it makes it tough to do much with.
Absolutely. Okay, we're almost out of time, but good stuff. Laiya, what good stuff do you have to share?
I'm just going to go ahead and make another plug for Medicine Pods and all the growing stuff that's coming out with it. You in particular are doing some unreal work with monthly newsletters and whatnot that I think people should subscribe to and give us some feedback on and let us know what they want to see more of, because it's been fun watching it grow.
I think for sure it's been a ton of fun to join forces with the Intern at Work, you, Zara, Allison. Totally agree. And we have another issue of Q Monthly. It might actually maybe come out a couple days before this airs, but either way, we'll include a link in the show notes. But that's it. All right, Laiya, thanks. Take care, and we'll chat again soon.
Thank you. Yeah, been a joy.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.